Hi, welcome back to the series of staying healthy and preventing COVID-19 infection during this period. In this video, we are going to discuss the current trends in the spread of COVID-19, what are our failures and how we fail to identify the new patients affected and even those who affected and, uh, and they didn't know that they are affected and they are now having enough antibodies to provide protection, at least temporary for the time being. The key issue here is the absence of accurate information of the number of people affected in the community or the country. The statistic, what you see, what you provided to us, is inaccurate, sometimes grossly inaccurate, and in most cases, it underestimates the prevalence. That means people actually having the disease, and also overestimate the death rate because we don't know how many people are affected. So without having a good statistically controlled random community testing as done in the Los Angeles and Santa Clara counties last few days, it clearly shows that a significantly number of patients or people are actually either had or having the disease and they have no clue of they are spreading the disease. So these important findings, the recent findings, have a major implication for public health effort to control the local epidemics. Secondary peaks, particularly taking tight actions in given localities, resource allocation, as well as preventing the public and the administration with the misleading data. So let's divide them into two categories. I'm going to discuss very briefly on the importance of antibody testing, which is not been done in most countries yet for COVID-19. So multiple community-based testing, as just I mentioned before, research indicated that there is a possibility, and indeed in this test confirmed, 20 to 40 or occasionally 50-fold higher number of people in the community are infected with COVID-19. This is not percentage, fold increase. We are talking about 4,000%. So it's a huge number. So this infection they may have had in the past, over the past 3-4 months, and antibodies will indicate that these people had the infection in the recent past. Whereas testing with the reverse transcriptase PCR technology will identify the people are actively involved infected with the disease. So there's a big difference between the two types of tests, and most countries are doing only the RT-PCR based test to identify who is actively infected. Because many of these patients, more than 50 to 80% of them have no symptoms. And even they have just like a mild viral disease like a common cold. So they taken for granted they had a cold, they had a good immunity, and they overcome the process on their own. So the antibody testing is helpful to identify person who had infection in the past. So PCR test is required to make a diagnosis of a current infection. So important to distinguish these two type of tests. Even though these antibody tests can be used for public health surveillances, as these recent studies over the last couple of weeks, it is unlikely, however, to provide information on any immunity in this individual against COVID-19. It's another interesting topic, and we have only very little information for the time being, but this will be clarified as time goes. Therefore, a large number of people in many countries having more than 20-fold of currently test positive patients. So administrations are grossly underestimating the number of people affected in their own counties, states, or indeed in the country. So those who with the asymptomatic carriers, with the if you do the testing is positive, and sometimes they have the antibodies as well in the early stages, they circulate freely in the community. And those who are susceptible with the poor vitamin D and insufficient immune system activity, they get the disease and get sick. So these people with the carriers in the community are unknowingly transmitting the diseases to others. So you see the importance of identify these carriers in the community. Without that, the system provided by the health departments are only half of that. So it's good that you identify the people with symptomatology and temperature extra and they quarantine or put in the centers to treat. That's only cover a third of these people, or actually even less than a third. So what about the other people they're walking around the streets and supermarkets and even in their own home? They are spreading the disease to others unknowingly. So this makes the whole disease spread related statistical prediction models worthless. So don't pay attention to any of these because they do not count the 20 to 40-fold differences in the prevalence of the disease in the community. Therefore, their models are completely inaccurate and the prediction are worthless. So in this approach, using antibodies, researchers need to test randomly, not the way they want or somebody from the street. So they should use a statistical model to identify the right people on a randomized manner so that the data can be applicable to entire state or the country. So it should be a representative sample of the general population and not a highly selected sample based on the bias, volunteerism or any other, the postal codes or any other means. So if you do it properly, as they did in Santa Clara, for example, they did very well sampling method, so that it can be extrapolated to a larger sector, including the extent of the spread, and to calculate the realistic mortality rate associated with the COVID-19, and indeed predict the number of people affected reasonably accurately and take the appropriate actions to prevent the disease. So you can see the disconnect between the two, and relying only on the diagnosed patient, very small number patient, and glorifying it as we are under control and nothing's going to happen. This clearly provides a false sense of security themselves, as well as providing the wrong and erroneous information to the government to make wrong decisions. So it's had to be careful of making such conclusion based on the wrong data. So these data give us clues on how many people might seek hospital services, including the potential requirement of the number of ICU beds if the studies are done in the community properly. Using the representative sample, those data are invaluable to plan and control the disease in weeks to come. So let's now address the calculation of mortality rates done for the COVID-19 very briefly. The mortality rate is calculated using the numerator, which is the top part of above the line, the number of deaths, and the denominator is the number of infection. So clearly you can see that if you don't know the number of infected people and it is wrong by the factor of 20 to 40, the outcome results of mortality rate is grossly wrong. It also provides the ratio of the deaths to the infection representing as a percentage. So that's why we call the death rate, which is basically a percentage. Whether it's 1%, 2% or 3% or in some countries 0.1%. So larger the denominator, the bottom part of the equation, is lower the mortality rate. So in most countries, the mortality rate are exaggerated, overestimated, because the denominator, the number of people infected, is completely wrong. So death rates also matters not only for the comparison between states, counties and countries, but also to provide information on the risks and proactively allocate resources to different parts of the country, including testing facilities and making informed policy decisions by the administration on social distancing and relaxation of the restriction. Let me tell you firmly that in the absence of making such decisions are just wrong and just based by the gut feeling, and indeed it's going to harm the country and their population. So in the current system of testing, antigen via the RT-PCR technology and identify the person with active infection is important and should be increase the numbers. However, this approach misses the diagnosis of persons who were infected and who are infected with lack of symptoms or had never tested before. That's part of the major problem. In addition, in most countries, testing is carried out only in those who are with the severe symptoms, like in United Kingdom. This causes a skewed the picture by introducing the selection bias, which makes the statistic completely worthless. A rapid antibodies test used by the above-mentioned counties is very suitable for the public health surveillance program. This is very, very important. This will allow to grasp the situation and to estimate the actual infection rate, not the postulated rate based on the hospital statistics. Such projects are essential to understand the picture of the pandemic or strategically address the needs of the society and resource allocation, and then moving forward with confidence with the knowing what's going to happen. Such antibody and antigen testing are needed in every 4 weeks in the community to make it a difference, as it's a dynamic system and it is changing on a weekly basis. So doing every 4 weeks is the rational thing to do, so that you can adjust the program, reallocate the resources, and make right decision and inform the public the truthful condition on what's happening in the community. So this will able to communicate to the public, and they understand the percentage affected, and they can take their additional proportion themselves rather than imposing curfews or other restrictions which are generally not going to be effective on secondary spread in the community until this threat is so, which might take a few months. So having addressed that, I'm going to talk about the herd immunity and the importance of community testing in more details in the next video. Thank you for participating. This is Professor Sunil Wimalawansa, Professor of Medicine from New Jersey, United States of America. Thank you.